Thank you, sir. That was great. We have a few minutes, a little bit less than earlier for questions, so feel free to step there to the mic. Andy?
So this is my question for both of the speakers, and it's probably of interest to the audience. What about the postnatal management of these babies? Sometimes the nursery isn't always aware that these babies have circulating antibodies that might impact their platelet count or their hematocrit going forward. What do we convey to the NICU
Sure.
or the nursery, and what kind of monitoring should be done, and how long are these babies at risk after they're delivered?
Yep. Great question. Thank you, Andy. So on the platelet side, what happens is typically their babies are admitted to the NICU, their counts are followed closely, and then once you see them actually getting up to a reasonable range on the right direction and over 50,000, these patients are then, assuming all is well, they're followed home. So they're going home quickly with their mom, but they're going back to the pediatrician to get the counts. So they need to follow. But once that you see the upward trend, they're followed serially because the antibodies, will have to wane. The baby will have to get rid of it. But it's that a really initial period that is the critical piece for the alloimmune patients.
Yeah, I would say, in contrast to that, the story is totally different on the rhesus side or any red cell side. And unfortunately, last year I was told of 2 cases, one on the East Coast, one on the West Coast, that had each 8 or 9 intrauterine transfusions. The babies were sent home to be cared for by their general pediatricians, and both babies were brought into the emergency room, DOA, by ambulance for severe anemia about 6 weeks out. So what you need to know as pediatric hematologists is when we do these serial transfusions, we suppress the fetal bone marrow. And these babies come out and they look wonderful. They're O negative. They sometimes don't even need much phototherapy. They go home in a couple of days with the mom, but the story's not over. So at about 3 to 4 weeks of age, they will bottom out their hematocrit. Sometimes the babies are symptomatic, many times they're not. So we actually set them up now as our protocol. They meet with the hematologist during pregnancy, the pediatric hematologist, to set up that first appointment at a week out. And they're seen weekly to have their hemoglobin and retic count checked. There is a study coming out of Leiden, I think pretty soon, looking at the use of EPO, which seems to have some benefit in these kiddos. They do not need iron. Their ferritin levels are off the chart because we've been transfusing them in utero. So one of the errors is we'll see the general pediatrician put them on, supplement them with iron, which is totally wrong. And so what they need is to have their retics and their hemoglobins followed. And when they get to around a hemoglobin of 8, they typically will need what we call a top-up transfusion. Sometimes it's 1, and the most I've ever seen is 4. So it just takes, and it's tincture of time. You don't need to do anything. You don't need to do a bone marrow biopsy or anything. They will come back. I believe it's because today we rarely do exchange transfusions. And because of that, we're not taking the antibody out of these babies' systems, so that antibody is persistent, and it suppresses that bone marrow over a long period of time. But eventually, as that antibody level wanes in the baby, it will start reticking again, and it will convert back to its own blood type. I get calls all the time. The baby's O negative, DAT's negative. What did you transfuse? I said, yeah, that's donor blood. That's what I've been putting in the baby 4 or 5 times. So know that the story is not over at birth. It's just beginning, and we really don't want to lose these babies afterwards. The general pediatricians have no knowledge on this. When I talked to my friends in Leiden, they were amazed that I send these babies to pediatric hematologists. And I said it's because when a baby goes to a general pediatrician, it gets a head measurement and a weight, and bye-bye, we'll see you later, maybe an immunization. So I send them all to pediatric hematology in advance of delivery to establish that relationship. And then I send, if it's a pediatric hematologist who's never heard about this, I tell them to call me. And I can't tell you how many calls I've gotten from pediatric hematologists and said, but you're maternal fetal medicine. I said, I'm kind of perinatal hematology, just put it that way. And I send them a couple of articles that have been published on this long-term suppression of bone marrow in these babies.
And I would just echo about our follow-up. When I'm saying peds, I'm literally meaning peds heme. Like they are the people that are following. If that didn't, if I didn't transmit that there, so yes, so they need to be followed.
Next question.
Hi, I'm Lisa Bodger from Chicago. I have the unique position of being an adult and pediatric hematologist, so I see all of our pregnant women. And the biggest thing I've seen, though, especially in FNAIT, is that they don't check the baby's platelet count with the first pregnancies routinely. So bloods are not checked on babies, and there's a huge reluctance, especially in pediatrics, to check blood or draw blood on any baby. So I don't know if there's any thoughts from or guidance of what we should be doing for basically all our babies, because we miss the first one or the setup, and then I'm seeing the woman who has a baby with an intracranial hemorrhage in utero or postpartum.
We have this argument all the time, you know. I know. What's you getting a CBC, or what is it to add the platelet? I know. It would be nice if we had it, but that's not the case.
Yeah, so they check, all babies are checked for bilirubin, right? So they do bili scans on the skin for bili, but know that we get cord blood at every delivery. Obstetricians are taught to do that. And that's for antibody testing and DAT testing, but that goes in the trash can. So we draw cord blood on every delivery. We've been doing it for centuries, but it gets thrown away. That no CBC is run on a baby that looks okay, but they check its bili and look at a bili scan, and that's about it. I think I'm headed to a NATE conference in Leiden in 2 weeks. I think there's a move, particularly in the Scandinavian countries, to screen all the mothers for NATE by looking for HPA-1 negative mothers. Remember, it's only 2% of the population. And so there is a move afoot to do that. I can tell you, I work with one company that can do sequencing and could sequence every mother at the time of her prenatal testing for Down syndrome and tell you if she's HPA-1 negative or not. I told them not to do it because I don't know what to do with the negative mother, because they can also sequence the baby at the same time and tell you if it's a positive baby. So what are you going to do with a negative mother, positive baby, but no antibodies? And so at this point in time, I don't think we have the data to know what to do with those. Europeans are trying to develop those protocols as they begin to do routine screening in Norway, in the Netherlands, and places like that in smaller countries. But we don't have an answer yet.
Sir?
Ravi Saradhar from UT Southwest in Dallas. Two quick comments. One about platelet transfusion in NAITP. In the blood bank, generally we get requests to get HPA-1 negative platelets for newborn who has severe thrombocytopenia. I think it seems that there's data to support you don't need HPA-1 negative platelets because it's very difficult to find them in timely fashion. And number two, any platelet you transfuse, what happens is it will mop up the antibody, and you'll still see significant increment in platelet counts. So in our place, generally we give IVIG to the newborn along with any platelet that we have that's compatible. And number two comment is about one of the differential diagnoses of thrombocytopenia in neonates. I think we should include congenital TTP because that's often missed when you have low platelet count.
Thank you. Any other questions? All right, last minute.
I have a question. Sorry.
Go ahead, of course.
Christina Haley, pediatric hematology at Oregon Health and Science University. In FNAIT, I'm always struck by the amount of bleeding that occurs, and I don't know if you have any ideas about why there's more bleeding in FNAIT than other thrombocytopenic conditions in the neonate.
Yeah, great question. I think partly it's the severity of thrombocytopenia. I think it's the binding of the endothelium, the vascular damage there, and probably some impairment on the platelet function as well.
Great, thank you.
Yeah, I think as obstetricians, we've always looked at numbers. We're pretty simple. We stick with numbers, which are hemoglobin, your platelet count. But it's pretty clear, particularly with this, as you pointed out, that I thought was great, that the fibrinogen receptor is very close to that HPA-1a antigen. And so it's probably a functional issue too. And that's probably why you still see some of these babies come out with lower platelet counts, but they don't bleed. And so the take-home message when I counsel patients is the IVIG is going to keep your baby from having a hemorrhage. It may still have a low platelet count and need some platelets after it's born, but it's not going to have the catastrophic outcome of a bleed. I'm just curious, how many centers in the U.S. are still doing cordos? I'm just, based on your data, I stopped doing them after you published it.
Yeah, I don't think, I don't know of anybody here in the States. Yeah.
There are one or two centers that have called me and said, shouldn't I do a cordo to offer the patient a vaginal delivery? And I said, well, yep, if you have platelets available at a Coulter outside the room, go ahead and bang yourself up and take the risk of 5% based on your paper, maybe higher than 5%. All of my patients, when I start talking about that, go, I'm having an elective section. I'm just telling you. That's what now, Europe is moving away from that, and they're doing vaginal bursts without cordo. And they're beginning to accumulate the data, and particularly the low-risk population you talked about, no previous intracranial hemorrhage. They're allowing more and more of these women who have been treated with IVIG, even be it a lower dose, to have a vaginal birth. So I think we'll move that way one day in the low-risk group that have been treated appropriately with IVIG, but we're not quite there yet in the States. So the majority of my patients end up with elective section. They just don't want to take a chance.
Right. One last question.
Roshni Kulkarni, I just have a question for excellent presentations, both. And Michael, for those babies, since the antibody wanes over time, what is the risk for intracranial hemorrhages, during the first few months of the baby's life?
Great question, Roshni. I think it's better than what's happening antenatally, and it's been reported. I think it's low, but it happens. Have you seen it in the baby so much? It's on occasion, because the cases I've seen is when the platelet count then drops again,
Right.
and they're at risk. That's the only time I've really seen it.
So they can have like microbleeds?
Yeah, yeah.
So they
Typically
should be monitored?
typically a minor one. Yeah.
So you think they should get like MRI?
Imaging, right? Yeah.
So I also wanted to put a plug in, because these are classic cases that should be seen in the combined clinic. We have OBGYN, adult hematologist, pediatric hematologist, and we did follow a mother who had ITP, and the adult hematologist took care of the mother, and the OBGYN took care of the OBGYN issues, and the pediatric person was ready when the baby was delivered. So great case for a total collaborative effort to, take care of these women and babies.
Yeah, totally agree.
Thank you. All right. Well, don't forget to fill up. You have another one? No. Don't forget to fill up the surveys and claim your CMEs. And from the foundation, thank you so much for being here.